Hey everybody, it's Andy. I'm sitting in the kitchen on an evening wanting to talk about back pain. So this is the week one lectures. Let's share some pictures. And so week one, of course, is the basics. We have to start here, and that means that most of you know most of this. But let's see what we come up with. I'm going to talk about the anatomy, normal aging, the common diseases that you really have to know, and we're going to work onto the core history and physical examination by the end of the day. When I get to the anatomy, I'm going to show you pictures, and you want to think about the bones and the joints, the cervical discs and facet joints, and the lumbar discs and facet joints. And then you're going to want to think about the muscles. There are a lot of them, and you want to just think of them basically as the ones that pull the neck forward and backwards and pull the low back forward and backwards and rotate. And you want to also begin to think of things that are segmental movers versus long movers of the whole spine or of one segment that stabilizes the segment. So here's a scary picture of the cervical spine, and I hope you see my arrow. You recall that C1 is a ring and C2 has a stick sticking up into it, right? That's the atlas and the odontoid, right? And a lot of flexion and extension occur, 50% of it occurs between the occiput and C1. You can see that the spinous processes have a hole on the side, variably 3 or 4 levels down. What's in that hole? Well, something you don't want to stick with a needle called the vertebral artery, right? Sometimes the vertebral artery actually doesn't go through the hole, even though there's a hole. So an X-ray or MRI scan guidance of injections is a bit sketchy out there. There are great big pillars of facet joints on the right and left side, and these can get arthritis. And when they get bigger, the place where the nerve comes out gets smaller. The spinous processes are often bifid, and that's because the bottom of the back of the spinous process there attaches to the right and left multifidus muscle, which are important rotators and segmental stabilizers. You've got these discs between the bones, and on the right and left side of the disc, the bone actually rubs, not in the middle, but on the right and left side. And that becomes a different kind of a little joint on the side, especially as we all get older. That becomes an important other joint that guides motion. The neck muscles. There are hundreds of neck and low back muscles, and actually knowing them is important. The more you know, the better you can get really fancy with what you're doing. So things that pull forward include the sternocleidomastoid, which you guys all know. And remember, there's a scoliosis anterior, medius, and posterior. And there can be spasms in those muscles. The brachial plexus runs through there as well. Deeper, right up against the bone, is the longus colli and the longus capitis that keep things stable, right? So those are the flexion muscles in front. In the back, you've got the upper you got the upper trapezius, and then the levator scapulae, which lifts the scapula, but also brings back the neck, right? Again, the splenius capitis and cervicus. Then a whole bunch of deep muscles, which become important, but I think in year one, we're not going to get into these in some detail, but the semispinalis, the rectus capitis, obliquus capitis, et cetera, right? And the very deep muscle that you'll learn more about, especially with EMG, is the multifidus muscle, which goes from a spinous process down to 2 or 3 or 4 or 5 or 6 or 7 transverse processes in the back. So it's a multi-pennate muscle. The lumbar bones, there's our vertebrae, those pretty thick-looking spinous processes. And the facet joints are oriented sort of front and back a bit more, and that changes as you go through the lumbar spine. This bottom one, of course, attaches to the sacrum, which I chose not to put in here. The spinous processes are outriggers. This picture is not quite right because the L3 spinous process is usually the longest one. That becomes important when people are trying to localize, is that really the neurologic L3 bone or the or not, especially when there are maybe 5% of people have an extra lumbar vertebrae or not enough lumbar vertebrae. And it's just because something fused to the sacrum or not, right? So the widest spinous transverse processes are usually at L3, anatomically and neurologically. It's like becomes kind of an important thing. Let's see, lower and upper facets. And of course, there's the spinal canal, right? There's your laminectomy over there. You can do a laminectomy. When you think about things that move the low back, you have to think, and people often forget about the muscles that move the back forward, okay? And here you've got all kinds of oblique muscles, the rectus abdominis muscle, the psoas and the iliopsoas are deep flexors. The iliacus is the only muscle that really attaches to the front of the sacrum, which is important when you're thinking about how do you stabilize the sacrum. The quadratus lumborum, and we'll go into a little bit of detail because it matters clinically and for EMG. Laterally iliocostalis, longissimus, multifidus, the intertransversaria. No, that's the spinalis is a trivial muscle, and the intertransversaria is also a very trivial muscle. So here's my baby talk. You've got the iliocostalis, goes from the iliac crest, to the rib, to the costalis, right? That's Latin for rib. There's a pars thoracix, which goes to real ribs. A pars lumborum goes to the ribs, to the tips of the spinous processes, because they were embryologically ribs. The longissimus goes down a bunch of transverse processes to multiple transverse processes. And the mother of all transverse processes is the posterior superior iliac spine, a place you'll use to palpate and feel motion. And that exists because all the lumbar longissimus attaches to the PSIS. So below that PSIS, there's no other muscles except for this one called the multifidus. And for every spinous process, there's one multifidus that originates there and goes down in the lumbar region 2, 3, or 4 levels. The one level is called a rotatory, but who cares? You can lump them together, okay? And what's cool about this muscle, first of all, is it is a segmental stabilizer. Second of all, it's got more muscle spindles than any muscle in the body except for the eyeball. Why would this stinking little muscle have such a fantastic ability to sense position? It's important, okay? And third of all, the multifidus, which originates at a spinous process, is all innervated by only one nerve root. When we get to EMG, the trivia question is, what muscle in the human body is only innervated by not one nerve root? And the answer is the rhomboids, C5. The other answer is at every single level, if you put a needle into the multifidus, it's only one nerve root that's denervated or not. So it's kind of a neat thing to test. The nerves at a microscopic or at a close-up level are kind of important because you remember there's the anterior horn cell, which is anterior, right? And it's the motor nerve cell, right? So anything between the anterior horn cell and the muscle causes denervation, right? On the other hand, the posterior part is the nerve cell in the dorsal ramus. Now take a look. If you have something happen like a herniated disc inside the spinal canal, it might spare the dorsal ramus, right? So when you get to an EMG, you'll often see in a severe herniated disc, there's severe motor damage, but the sensory nerve conductions are perfectly normal, even though the person can't feel a darn thing. And it's because the nerve is completely in continuity from the foot all the way up to this cell. It just doesn't communicate medially because of the herniated disc, okay? So the anterior horn cells in the spinal cord and the sensory fibers are, the nerve cell is in the dorsal root ganglion. The autonomic fibers hide up here, and there's a gray and white ramic communicantes, which are scary to me because they do different things. Ventrally, you get the big nerve root that goes down to the leg or the arm, right? Dorsally, you get the posterior ramus, and there are 3 branches. And this is kind of helps you understand the anatomy of pain as we go forward. The far lateral branch goes to the iliocostalis muscle and out to the skin. So if you have somebody who has segmental losses feeling in their skin, there's been something damaging there, probably a compartment syndrome, which is very rare. The intermediate branch goes to the longissimus muscle, and it's a pretty complicated relationship, almost like a complicated brachial plexus, except for on the back. Like at one point we were tubular worms and we were symmetrical front and back, and it still stays like that. The medial branch is famous for medial branch blocks, which you or others may end up doing to denervate or to block the facet joints. If a facet joint hurts, we'll try to do a medial branch block. But that medial branch also goes to the multifidus muscle, which is a segmental stabilizer. It also goes to provide innervation for the nerve root sheath. Think about that, and we'll talk about this. Nerve or spinal nerve roots don't feel pain. If you cut a nerve root surgically, you get tingling, but not pain. The nerve root sheath, when it gets inflamed, sends a message to the posterior primary ramus that something's hurting. Right? So the pain of a herniated disc is not from nerve damage, it's from inflammation of the nerve root sheath, okay? Of course, these roots go out and become the lumbar plexus or the brachial plexus and go out to be peripheral nerves, which over time you're going to get really good at understanding all the anomalies of these and everything. You'll become quite a nerve expert. Remember, the spinal cord ends at about L3, and after that you have the cauda equina, which drips down from there, a whole bunch of little nerves floating in the spinal canal, right? You don't have a spinal cord injury in the lumbar region because there ain't no spinal cord. That means you don't have spasticity from a lumbar pain. If you see spasticity in someone with a lumbar pain, you better look for something else. So I guess I talk about that here. You don't feel discs. I didn't get there yet. The lumbar discs don't have sensory fibers except for posteriorly, and even back there, they're kind of sketchy. So if there's a herniated disc anteriorly, you won't feel it. You see it all the time on scans, and it's not a painful event, okay? If the disc herniates up into the bone, that can be a painful event because the bone can feel it. And eventually that becomes a Schmorl's node, which is like a little bony caved in thing on the bone. But by the time it becomes calcified, it doesn't hurt anymore. If it herniates backwards, sometimes it touches up against the rare sensory fibers along the back of a disc. That hurts, causes pain. Sometimes it doesn't, and then you get a herniation without pain. As you know, I think 1/3 of people without any pain have a herniated disc, right? Facet joints. My friend Augie and I did this funky study where we shocked a bunch of pigs in the facet joint, and it caused a very characteristic muscle spasm. So like if we shock the left L3 facet joint, then you'd get left, I don't remember, L2, 3, and 4 multifidus spasm, and right-sided L2 and 3 spasm, something like that. It kind of is neat to know that because this explains what muscle spasm is. It's almost always the reaction to a pain someplace else, and it's often very characteristic related to a facet joint. Somebody has a lot of muscle spasm, they get a facet joint injection, it all goes away. That's kind of wild. As I said, the multifidus muscle is a really important sensory organ. They've done these funky studies where people have their eyes blinded and they're vibrated so that it temporarily denervates the multifidus, and people don't know where the heck in the world their spine is. We also do this experiment when we, let's say, operate and remove a bunch of back muscles, right? Or when we do a radiofrequency procedure. So there's a consequence to damaging those muscles beyond the strength aspect. We talked about this, nerve roots don't hurt, nerve root sheaths do. And this posterior primary ramus is important for us in understanding facet joints. Referred pain is something that I think you understand for other purposes. When you get a heart attack and it's in your left arm, but you know the heart isn't in the left arm. And this is super important because there are lots and lots of mechanical pain generators that sound like nerve problems, okay? So you can get a spasming muscle in the neck and it shoots down the arm. You can get a painful facet joint or sacroiliac joint and it causes pain down below the knee, okay? So even though classically we're taught that pain down below the elbow or pain down below the knee is nerve, it ain't necessarily so because there are a lot of reasons why stimulating a facet joint causes a sensation into the spine that does not know how to interpret it. So it interprets it as the next closest thing that it does know about, which is the nerve. So there can be sclerotomal radiation. That's what we call that. The really important thing here, though, is if it's caused by a facet joint, you ought to be able to make the facet joint hurt, okay? So if you think there's sclerotomal pain, you better find the thing that causes that pain, or else you need to keep thinking. Normal aging will be the bane of your existence, because normal people and dogs and cats and dinosaurs and elephants and mice go through changes that are normal. And these are not disease. I think if somebody uses the word degenerative joint disease again, I'm going to slap them in the face, because as all of us genetically, according to Charles Darwin, have survived for billions and billions of years, it's because when our brains get squishy and stupid, our spines are stiff enough to jump out of the way of the lion, okay? So the normal process of aging is often labeled as a disease, and it goes something like this. You can get tears to the annular fibers. By the time 18-year-olds were killed in the Korean War and they did autopsies, they showed that there were fibers, annular tears. And by the way, about 50% of kids by the time they're 18 years old have had an episode of back pain. So a lot of people think that these episodes of back pain people get are, oops, tore another annular fiber, okay? The tears can eventually cause a herniation. So you can get a herniation. And as we talked about, a herniation can hurt or not hurt, okay? And so in young to middle-aged people, less commonly when you get older, herniations can cause a radiating pain because they irritate the nerve root sheath, okay? Herniations can cause discs to collapse kind of not so gracefully and cause some pain I'll talk about in a minute. But honestly, with aging, it's not a degenerative process. It's a change in the configuration of the proteins in the disc that make it collapse down and be stiffer, okay? But when the disc collapses down, then the facet joints begin to bear weight. And guess what? A facet joint bearing weight can hurt or not hurt, okay? And so you'll see that in middle-aged to older people, you're more likely to get facet joint related pain. You only see it in young people like gymnasts who are doing crazy things with their facet joints. Now, guess what? When you have bigger facet joints, there's a smaller spinal canal, right? That causes impingement of the nerve, or maybe not. So we're going to have a long discussion about spinal stenosis, radiologic spinal stenosis, which means the spine canal is small, versus this disease, which is called spinal stenosis, which has neurogenic claudication, okay? And eventually things get really stiff, and then guess what happened? Either rigor mortis, or when you die at the age of 100, like my grandfather did, your neck doesn't move at all and it doesn't hurt at all, okay? So patients who think I'm going to have this pain, it's going to get worse and worse and worse until I die. The fact is that as long as they don't get their brain practicing the pain and paying attention to the pain, eventually they get stiffer and all these things resolve. So the picture looks something like this. There's your normal disc and spine, and maybe there's a tear in the annulus or something, I don't know. But then there can be some of that gel in the center squirting out, causing a herniation. And of course, that does cause a bit of a collapse too. The herniation is bugging a nerve there. Then as things collapse further, the facet joints begin to bear weight, and they could hurt or not, right? And then as you get really old, everything's just stiffer than heck. So that's the Kirkcaldy-Willis's degenerative cascade. Begs the question, if normal people have tears and herniations and collapse and stiffness, what can imaging diagnose? Cancer, infection, fracture, but then not real much. You gotta quit looking at pictures for the answer, okay? Here's what you can find that is more likely to be causing pain if you see it than not. Seronegative spondyloarthritis, right? Ankylosing spondylitis in the sacroiliac joint. Juvenile idiopathic scoliosis at a certain angle. This begins to be a trouble, and it's good to see that in a young person. But on an adult, if you see scoliosis, it's got to be pretty big before it correlates with pain in a population. So if somebody comes in saying, I've got scoliosis, my wife noticed it. You're like, yeah, but I wonder where you hurt, because I'm not going to buy that as the cause. Spondylolisthesis. We talked about this in our sports lectures. In adults, it only correlates with pain if there's a slip of greater than 25%, a grade 2 or greater. But even then, if you see that on an x-ray, you better examine the person to see if it's a facet joint or a herniated disc or something else. Just because you see a spondylolisthesis does not make you stop examining the patient. And there are some weird anomalies that we know correlate with pain, and they're kind of cool when you see them because you go, aha. So people are born with a hemivertebrae. They can have a transverse processes that reaches out and becomes a joint against the sacrum or against the iliac, against the pelvis. And those can correlate with pain. So there are a few things you see, but they're really rare, okay? The rest of the things that you learned in medical school that cause pain, and almost everything you learn in medical school can cause pain, imaging can only confirm your clinical suspicion. So don't get in the habit of looking at images or hearing about images until you've already set up a hypothesis. You will be dragged down the wrong way. So here's my poem. You can't ever call it sciatica until you poke the trochanter, whip the hip, smack the sacroiliac, and upset the facet. And that's going to be part of your exam on every single patient long before you look at any imaging. So let's look at basic and more advanced causes of back pain, just so you've got them in your vocabulary. Look at this MRI. This is an annular tear. See that little white part there? See it right there? A little tear in the annular fibers. They cause non-radiating pain, but guess what? I cannot tell you by looking at this picture whether that annular tear is causing pain or just living there. They've done stupid things like discography, where they inject dye under pressure, and if it causes pain, they say, oh, that's an annular tear that causes pain. Let's fuse the spine. And then somebody figured out that the response to a discography is mostly related to the psychological status of the patient, and that is widely condemned these days. Facet joints, and you can see over on the far right here, a facet joint. There's another one. They also cause non-radiating pain. The pain on examination is with rotation and extension. So if you have somebody twist their chest over to the right and arch their back into the left back, and they say, ouch, in a spot, that's a good sign of facet joint pain. Beyond the physical examination, the only way you can prove it really is by doing a fluoroscopically guided injection of anesthetic into the joint. The person says the pain's gone for an hour, and that's a good test. The sacroiliac joint also causes non-radiating pain, but more often than you'd think, radiating pain. The patient points to the sacroiliac joint. This is called the Fortin finger test. Joe Fortin named it after himself, and they say, I heard here. And you're like, well, I guess that's where the problem is, right? On your exam, you can feel that the sacroiliac joint is tender. And there are a bunch of other maneuvers that we use to try to cause the sacroiliac joint to hurt. Again, X-rays, MRIs, CAT scans cannot prove that this joint hurts. The only way you can prove it is with a fluoroscopically guided anesthetic injection. Spondylolisthesis and spondylolysis. And I'm going to show you pictures of all these things in a minute to recap. They can cause non-radiating pain in young athletes because a spondylolysis is kind of you kind of think of it as little microscopic cracks happening, although it's not quite this, it's not quite a bone fracture. So that's non-radiating pain. And especially with a listhesis, it can slip enough that they get radiating pain and even nerve damage. Usually in young athletes, in adults, spondylolisthesis is usually not a cause of pain unless there's a substantial slip, and it doesn't slip very much in people over time. The person would be tender at that area. Often tight hamstrings are a clue. And sometimes in a skinny person, you can actually palpate that step off. A lot of times I order the film and I go, oh, I'm going to find a spondylolisthesis. As we talked about with athletes, especially in young people, you don't want to radiate them unnecessarily. So if you get a spot lateral film and it confirms a slippage, you don't need anything more. If that's not clear, and if you need to know, the oblique films show that Scotty dog with a broken neck, if you remember that from medical school. And CT scans can help as well. MRIs will show this, but sometimes it's kind of confusing because the soft tissues around those and the facet joints near them make it a little hard to sort things out. Disc herniation, that's your friend, right? classically pain radiating below the knee, but here's an important trick. High lumbar disc herniations are missed a lot. They're not real common, but they're missed a lot. And the reason is the pain isn't below the knee, it's into the anterior thigh. So you have anterior thigh pain, you get worried, right? The reflex for those is the patellar reflex, and it's usually normal. Straight leg raise test is negative. If you bother to do a reverse straight leg raise test, it might show something, but it misses it about half the time. And MRIs miss a lot of these because they're in older people who have all kinds of degenerative changes, hypertrophic changes, and they're far lateral, usually not in the midline. So they're not like sticking out into the spinal canal. So they're missed quite a bit. And if you find them every once in a while, you know you're really doing a good job, good doc. But in general, the L4, L5, S1 herniated disc nerve root problems, a positive straight leg raise test, asymmetrical weakness or reflex change, 2 of the 3 is pretty darn specific, according to my friend Tamara Lauder, who did a very nice study on that. If it's a young, healthy person and it's the only thing you see on an MRI or a CAT scan, you don't need to do an EMG. You just say that's what it is. But how often do you have a apparent herniated disc in a diabetic, or in a person who's got not a classic physical exam, or in a person who's got other degenerative changes on the scan? In that case, the diagnostic test is an EMG, period. In fact, EMG is almost as good or as good as an MRI with overlapping sensitivity and specificity. So you could go with the EMG and forget the MRI. It's just you need the MRI if you're going to do something like an injection or surgery. Spinal stenosis. This is a disease that my team's gotten some of the world's top research awards for, because we showed that we didn't know what we're talking about, right? So we'll get into this more later on, but the disease is neurogenic claudication. You say to the person, how far can you walk? Oh, 100 meters, I have to stop. What if I put a gun to your head? I would just collapse. I can't go further. I cannot keep going. Why? Well, either they'll say I've got pain in my legs, or I begin to walk like a drunk person because I can't feel my legs. That's called neurogenic ataxia. Okay. Well, okay, we stop walking, but I make you stay standing, and they get this look of, oh no, I've got to sit down. I've got to bend forward or do something to open up my spinal canal. That's neurogenic claudication. There's often back pain with spinal stenosis, but it's not caused by the stenosis. It's caused by the facet joints or something right around the area that moves a little bit, causing a tighter canal when you're walking or standing up. Okay, so if somebody says I got back pain from spinal stenosis, you look at the back pain from the joints near the spinal stenosis. You don't treat facet pain with surgery. So if most of the pain is facet or back pain, you don't want to treat stenosis with surgery. So your exam might show significant neurologic deficit. It might show symmetrical deficit, which looks maybe sometimes like polyneuropathy, but it won't look like that on an EMG. It may show symmetrical reflex, the absence, or asymmetrical. MRIs are absolutely useless in proving whether somebody does or doesn't have spinal stenosis. That's one of our big studies. EMG, when positive, is nearly 100% specific. Okay, and it localizes the nerve root. Okay, so you're going to learn to never look at the MRI for stenosis, except for if you're trying to put a needle somewhere. So here are some pictures, right? On the upper left-hand corner, you see the Scotty dog being cracked. That's the spondylolysis. And going to the right here, you'll see that you can get a grade 1 or grade 2 or grade 3 or grade 4 slip based on what percentage slip. Grade 5 is called a spondyloptosis, which means L5 has fallen completely off of L4. Weirdly, you can actually get a spondylolisthesis at L3 and L4. Trivia thing, javelin throwers for some reason get those. Don't ask, I don't know why. You've seen a lot of herniations in primary care, right? And there's a herniation sticking out of L5, okay? And this is a picture of radiologic lumbar stenosis. What did I tell you? This person may have no symptoms at all, but okay, there you go. Okay, and I'll talk about that later. But this is a spinal canal that's pretty tight. There's nothing on this MRI that can tell you this person hurts. Dangerous causes. all of you have a good primary care background, and I really doubt you'll miss any. And I think these get overblown. The exercise that I'm going to teach you, if you were to staff a case with me, my first question is, what killed the patient? And the exercise is, don't say, what are all the things that could be dangerous in an individual case? You'll get bored really quickly. But if in every person you see, you go, what's the one thing that killed him if I missed it, right? 23-year-old young man, testicular cancer, 75-year-old old woman, maybe her breast cancer, et cetera, et cetera. So you always think about them by just thinking of one cause in a person, never zero causes, never six causes. Just think of one, and if it sticks to your brain, you'll never, ever miss one. So we worry about cauda equina syndrome, infection, cancer, and unstable fractures. Cauda equina syndrome is progressive bowel, bladder, sensory, or motor changes, okay? It progresses over hours to a day or two. It's a medical emergency. The faster you decompress, the more likely the person doesn't have to use a catheter for the rest of their life, right? Some of these people have no radiation of pain. Why? Because the posterior primary ramus isn't inflamed around the nerve root sheath. It's right smack in the center. Cauda equina syndrome occurs in about 0.7% of people with a herniated disc. So it's really rare. And it's not caused by a particular activity if they're running or jumping or anything like that, right? What it is instead of the inflammatory thing happening, the disc really truly occupies the whole spinal canal and pinches everything off, right? Your examination is going to look for neurologic deficits, and you'll get to the point where you look at rectal sensation and tone if you really are worried about this. MRI or CT scan are really good. There are times when these are unclear or unavailable, and you can do an EMG of the anal sphincter, among other things. Infection, fever, night sweats, infections elsewhere, prior surgery in the last 6 months, dental work or dental abscesses, people who are immune compromised are at risk, right? But they're going to kind of tell you. It's kind of funny, but there was a study done that showed something like 6 or 8 weeks between the time that the medical record showed every indication of a disc infection and the time that it was actually mentioned in the record. So they do tell you they've got an infection, okay? If you only I'm a diabetic and my back hurts and I can't get comfortable. Wow, you're diabetic. What's the one thing? Oh, it could be an infection because you're diabetic, right? I had breast cancer 10 years ago and I'm completely cured, but now my back hurts at night, right? They tell you, you just have to be thinking of one, right? So you can't fall asleep at the switch. So you sometimes they look sick, hot. A lot of times they just don't look comfortable. A plain x-ray and a sedimentation rate are pretty darn good, okay? Obviously an MRI is definitive. CT scans aren't very bad either. Cancer, if they had a history of cancer. Some research, and the classic story is they have night pain. They wake up from their sleep in pain. That's not quite true or as strong a thing as you think it is, but it can happen. Again, the exam can miss it. You just have to be curious. But they're sick looking. They can't get comfortable. Sometimes you find neurologic findings, right? Again, that X-ray and sedimentation rate acutely are really great. Those are good tests. So your first line test is X-ray sedimentation rate. MRIs find them. CAT scans are pretty good too. Unstable fracture, duh, they got smacked, right? Now, what's kind of scary when you do rehab consults on a trauma ward, at one point in the US, something like 10% of people admitted to a rehab unit from a trauma ward had a previously undiagnosed unstable fracture. The trauma team is busy dealing with the femur fracture and the aortic aneurysm and the brain injury and all this kind of crap, and they miss it all the time. Now, protocols are better, and a lot of times, any trauma case gets a full spine X-ray or CT scan or something like that. But you're going to have people missing these, right? So when you are on a trauma ward and looking at something else, you want to be the paranoid person who says, I'm not doing with this person until I see a complete spine X-ray and I've palpated and nothing's happening there, right? Point tenderness and deformity often enough. X-rays are pretty darn good. CTs can define things better, and MRI, those two can guide treatment, like if it's impressing the spinal canal, if you've got some other instability. Medical causes of back pain, diseases that cause back pain. There's a whole bunch of them, but we'll go with a few here, right? These seronegative spondyloarthropathies, there are a lot of them, and it's kind of neat to pick them up. And especially with disease-modifying anti-arthritic drugs, you can do something about them. There's a long rheumatologic refuse systems with fevers and night sweats and skin rash and bowel irritation and dry eyes and dry mouth and oral ulcerations, genital ulcerations, food poisoning, venereal disease that you kind of rattle through. And if somebody sounds like they've just had recurrent sacroiliac pain over and over again, maybe you find a particular one of these diseases that has that is the cause. Your exam may show the sacroiliac joint is tender. Trunk flexion at some point becomes limited, not right away. The Schober test is 15 centimeters above and below the posterior superior iliac spine. Make marks, have them bend forward. If it's less than 4 centimeters when they're fully forward bending, that's a positive test. You can put a tape measure around the chest, have them take the deepest breath and then let it out. And if the chest expansion is less than 4 centimeters, that's kind of a good test too. Sacroiliac view x-rays are better than plain x-rays that are apilateral. MRI of the pelvis is pretty awesome, but still these can creep up before somebody has a positive scan. The HLA-B27 genetic test is a big deal for these, according to a lot of people, but it really has moderate sensitivity and specificity. You'd never use it to rule out or rule in, but it kind of supports your thoughts, okay? The history is really the deal here. Sickle cell disease, I think you're probably a lot more expert than that on that than me. People show up with that a lot in the US as well. Kidney infection, pelvic organ diseases, aortic aneurysm. One of the scarier things in my life as a young medical student was the two guys that came into the hospital wanting to get their welfare checks filled out. One guy was full of crap, faking like crazy. We went to see his next door neighbor and the guy was dead. And what happened is the one guy had a backache that was an aneurysm. The other guy thought it was a good idea to call in sick, right? So these are scary. Myopathy and other things like that you can think of as well. We don't have enough time in the world to talk about scoliosis, and most rehab doctors don't deal with juvenile idiopathic scoliosis unless they subspecialize. If you do, there's much more to learn, but I'm going to give you one slide on it, okay? In adults, we talked about this, right? A little curvature is nothing. Everybody who's right-handed, their right shoulder droops. In fact, if it doesn't, you're wondering what's wrong, okay? Suspicion if there is a bigger curve or if the curve is really focal and painful. And when there's focal scoliosis, you start thinking about cancer, infection, fracture, compression fractures, right? If it's non-focal, you can at least consider muscle or nerve diseases, although in adults, that's usually not the cause. In kids, the thing you know about most is juvenile idiopathic scoliosis. And again, there's a really important paradigm to learn if you're dealing with these kids. Basically, what is the angle of curvature versus what is their skeletal maturity? And that leads you to observe them, to brace them, or to recommend surgery. Something to really know, though, is the damage caused by clinicians poking and prodding on the backs and butts of young girls, okay? There's a lot written about the braces kind of causing them to feel really inadequate. And there are all kinds of different psychological traumas caused by people not being sensitive to the fragility of the sexuality of these young girls. So dignified and careful and be, watch out for something that you don't want to do. There's a thing called Scheuermann's disease, Scheuermann's kyphosis, right? So they're bent forward, right? And you'll see people with their head hanging out in front of their chest pretty far, or young people have a lot of pain up and down their back and kind of a bit of a forward head posture. This is caused by changes to the end plates. And these people will often have those intravertebral Schmorl's node herniations, right? So x-rays can often find it. Bone scans, MRIs will also see this. The treatment there is most often a lot of exercises into extension, sometimes bracing. I've seen one case that had surgery. A really cool thing to understand is if the curve looks like a forward S, if you're looking at their back and it goes from the right side down to the left side, back to the right side and down to the left side, it's a forward shaped S, then you go forward with trying to find out if there's a nerve, muscle, or bone disease, okay? If it's a backwards S, that's much more typical of juvenile idiopathic scoliosis, okay? So a forward S means go forward with testing. Any funky business, a physical exam, spasticity, et cetera, you're throwing out juvenile idiopathic scoliosis and looking for other causes as well. Okay, this is my favorite slide because it's, you know about all these diseases and I want you to forget them, okay? This is things for you to forget because every stinking medical textbook mentions them and they're stupid, mostly. Piriformis syndrome. My definition is it's a herniated disc that you missed on the MRI, or you forgot to do an EMG in the paraspinal muscles, or you forgot to poke the trochlear, the sacroiliac. Also, sometimes a therapist will equate piriformis muscle pain, which can be a real thing, with the piriformis nerve entrapment syndrome, right? The real syndrome is the impingement of the sciatic nerve in the very few percentage of people where the nerve actually goes through the muscle, okay? This is something that was really popular in the early 1900s, and people operated on hundreds of cases and had them recuperate in the hospital for a month, at which point, don't tell anybody, but their herniation got better, right? Completely stupid. And that continued in textbooks until I wrote a paper in the 1980s showing that nobody had ever presented a reasonable case ever in history with neurologic EMG findings. My friend Mark Goddard found a case, and more cases have come. It does exist, of course, but it's really rare. I've seen 2 legitimate cases, and I look all the time because I wrote that stupid paper, right? So when the PT or the orthopedic surgeon says it's piriformis syndrome, you say, let's look again. Probably not, right? Thoracic outlet syndrome. Pain from the neck down into the arm to the 4th and 5th digit. Oh, it's got to be the lower trunk of the brachial plexus. No, it's mechanical neck pain, and you missed the ulnar neuropathy. And you missed it because you didn't look, or you missed it because actually EMG is not so good for that particular neuropathy. EMG misses about 50% of people with clinically obvious ulnar neuropathy. So, it's almost always mechanical neck pain plus the person has an ulnar neuropathy that we didn't treat, right? In fact, thoracic outlet is impingement of the lower trunk of the brachial plexus, the axillary artery or vein. You can get neurogenic or vascular thoracic outlet syndrome. It's almost always under an anomalous cervical rib, or if not the rib, an anomalous band in that area, right? The scandal here is that a guy named Urschel was the big fancy guy who wrote up this stuff in JAMA and published on it all the time. And after he died, somebody did analysis of his pictures and showed that he was faking his data, okay? Bummer, huh? Because we got a whole generation of surgeons thinking they know what they're doing, and Urschel's stuff doesn't die quickly. The Mayo Clinic has seen more complications from people getting thoracic outlet syndrome surgery by idiot doctors than they've seen actual cases. Now, here's the deal. You will see a few cases. I've seen a few cases, but they're almost always like a thin-necked woman with an anomalous rib. And there's a whole bunch you can do with EMG to try to prove this, okay? I'm not even sure EMG is perfectly able to find true neurogenic thoracic outlet syndrome, but it's pretty darn rare. So be very skeptical and don't let somebody fillet open your patient's chest because they think they've got piriformis syndrome, okay? Osteoporosis. Oh, I've got osteoporosis and that's why I hurt. Osteoporosis doesn't hurt, okay? So my definition of osteoporosis pain is go look for something else, okay? Fractures can happen with no pain too. So you can see osteoporotic fractures in people who have no recollection of any pain. They can cause a deformity which causes pain. My favorite one that you'll see in people with fractures is their ribs begin to rub on their iliac crest, and that's pretty obvious. Or they can cause people to begin rubbing on their facet joints below or above the fracture or whatever. So osteoporosis fractures can cause all kinds of pain things, but the osteoporosis itself is a bad disease. The really red flag that I'll talk to you about later is, number one, if it's a man, it requires a workup. If it's a woman, listen in to other medical problems, thyroid disease, diuretics, alcohol use, steroid use, et cetera. But with guys, you really want to find an answer. Really important as a rehab doctor, when you're referring people to therapy, one of your obligations is to list the contraindications and cautions. Anybody with osteoporosis should never, ever do any flexion exercises, either to strengthen their abdomen or to stretch themselves forward, okay? Any configuration of a flexion exercise increases the chance of fractures. Extension exercises only decreases the risk compared to doing nothing, right? So if you've got a person with osteoporosis and you're sending them to therapy for something, no flexion exercises of any kind, emphasize extension exercises, right? Okay, a couple of cases to wrap up today. And these are just for fun. This person has pain in the low back going into the right hip, and you see my little yellow or red, what color is that? Blue mark around that lumbar spinal stenosis, right? Yeah, but on my exam, she just hurt around her sacroiliac joint, okay? If you look at my little arrow, can I move it? Where's my arrow? It's hiding. It's hiding. I can't show you. There it is. There's the sacroiliac joint. I cannot tell whether that joint hurts. There's that really tight spinal canal. It's not why she hurt. It's not why she hurt, okay? This person had back pain and leg weakness. And look at that tight spinal canal. Oh, we'll come back to this picture. I just noticed something else on it, right? Yeah, the problem is that on the EMG, her nerve conduction velocity was 28, which is Charcot-Marie tooth disease, the most common familial neuropathy. Here's a little trivial thing. You see the iliopsoas muscle, how dark it is? You see the paraspinal muscles, they're the same size. They're not shrunken, but they're moth-eaten, okay? That's kind of a neat thing to pick up. And at some point when we get fancy about MRI scans, you want to keep looking at the muscles that the radiologists never look at. And you'll see atrophy in denervation or disuse, which predicts bad outcomes. Or you'll see fatty replacement in muscle diseases, especially older people, which is a big problem. This person has back and leg pain. Again, a super tight spinal canal. You can't tell if those facet joints hurt by looking at a picture. Okay, you can't tell. Are you paying attention to the paraspinal muscles and the iliopsoas? Some problems there, right? This is worse with walking. This is spinal stenosis. The EMG was even positive. There's an L5 radiculopathy. I think we should operate on their back. Except the leg pain was at 3 miles, 5 kilometers. The back pain was clearly mechanical. Spinal stenosis is not the cause for back pain, even in people with spinal stenosis. And the person had a hip flexion contracture. And if you want to walk 3 miles with your hip bent forward and not hurt, I want to find out about it. So I hope this is setting you up to start thinking about the complexities, okay? So for this week, before class starts for real, you should have a copy of my acute patient questionnaire, my physical exam form, and a little card I wish I could print out for you that has yellow flags and red flags, okay? Your homework, and you may have to do this over the next week or so, is do that darn physical exam on friends and patients until it's just natural. When you have challenges, come back to me, because I really want you to be good at that and not have to think about it, okay? And then see if you can come up with one case where you wonder what to do for a diagnostic test. If you have some images and we can put them on the screen, that'd be great. That's quite a bit. I will say good night to you all and good morning to those of you on the other time zones. And we'll talk in a session a little bit later.